parts. First one is imaging acquisition. Second one is imaging post-processing. The third one is diagnosis and risk prediction. So AI recently AI progressed rapidly, and in all the three parts. So this speech I will introduce the AI in the three parts. First one, image acquisition. As we know, the most important thing or important problem of CMR is the complex processing and the long scan time. So the hard research issue is how to simplify it and shorter the scan time. So AI do some work here. Now we can. This acquisition includes mainly three parts. First one is localizer. It's very complicated. And third one is the function evaluation. We use MR thinning. And the third one is evaluate the fibrosis. We use MR-LGE. So first mainly part, localizer. So how to use AI? So now we don't need manually localization. This procedure cost average time is 5 minutes and so on. So now this part can automatically localized. So this is made this part. So AI drive made this part automatically simplify and short, and scan time is shorter. The second part of the cardiac MR is to evaluate the function of the cardiac. It is called CMR thinning technique. So how to use AI to make it faster? The thinning procedure costs 10 minutes in average. So how to shorten it? We look at this PPT shows the mechanism of the AI-driven fast thinning protocol. As we know, here is the case base. As we know, and the right point is every red point is the acquisition information we get. So as we know, case base has a characteristic. The central part of the case base is reflect the CNR of the imaging, and the peripheral area of the sequence of the case base reflect the detail. So how to use AI to make it faster? We only the lower part. We only get the central part of the case space and leave the peripheral area as 0. So the imaging like this, the lower part has the black and white, has CNR, but the detail is bad. The CNR is good and the detail is bad. But when we only get the central part of the case space, acquisite the central part of space, the filling time is dramatically decreased. That's the mechanism of how to faster the sequence, how faster the imaging. So but use the only central filling. We get the imaging like this, very bad image quality. So the AI night has the power that we can tell the AI, we get this image, the lower part, and you should be like this, the upper part. So we tell AI, so you do it. And after training, after hundreds of images training, or millions images of training, okay, the AI has the power that when we input the imaging like this, the lower part, and he output the clear imaging. Clear imaging. So this is called the so how to say 生成式 AI generative. Okay, you understand understand Chinese. Okay, this is so this technique this technique published in last year. So now we use it and shorten the cardiac thinning into one breath hold and 10 seconds. And this paper published in Radiology. Okay, another so AI also can do some image quality control, and the third part of the acquisition is LGE. LGE is very important in cardiac MR. It can evaluate the fibrosis of the myocardium. So the rapid LGE. The rapid LGE has some we try a lot of method in this part, but now we cannot resolve it because LGE need very accurate evaluate. So AI cannot make the accuracy of AI is not sufficient right now. So I will introduce a paper published, a technique published in Circulation last year. Still use the AI night like I just introduced. This method we get T1 mapping and LG T1 mapping and CMRI. So the scan time is shorter. We don't need to insert. We don't need to inject contrast medium. And T1 mapping give us the tissue characteristic of the myocardium. MR thinning give our function and structure of the myocardium. So combine these two information together, we can generate a visual LGE. And this paper use this technique. This paper gave our a point that the fake LGE also same as the real one. So this gave us a new method to consider the LGE, how to get the LGE. But we cannot use it in the clinic right now. But it has a very bright future, I think. And the second part of cardiac MR is image post-processing. Post-processing include mainly two parts. First one is evaluate the structure and function of the cardiac. Another one is LG evaluate. Now, as the speaker just mentioned, we have several software. Some is public and some is in the lab, in the lab center. And now we can use artificial to AI to automatically identify the border of the myocardium, so we can automatically analyze the MR, the cardiac function and structure. Is this accurate or not? And do cardiac segmentation and cardiac function. And wall measurement. Our lab also do some work here. We promote a software to evaluate the cardiac function and structure. We make some new point, but now it's not ready. So maybe next year I will introduce this system. A paper published. So how about the accuracy of the AI-driven airway function evaluation. There's a paper, several paper published, shows very good correlation with airway function driven by manually process. But as our experience, automatically function evaluation is not very accurate, especially in the basal part of the cardiac So need a lot of manually correct. I think the future of this part to automatically evaluate the function of cardiac is to make it more accurate, especially in the basal part of the cardiac. The second one is a second part post-processing is automatically identify the LGE. So this part is not done right now. So all the software, all the research in different center cannot make this part automatically. Why? Because the margin of the cardiac in LGE sequence is very difficult to identify. Even personal, even me, even experienced expert sometimes cannot make clear where is the margin of the cardiac of the left ventricle in LGE sequence. But still some work. But this is I think this is a very important part of cardiac post-processing. If we cannot make this done, it's not automatically post-processing procedure. So next, I think the very hard research issue is this area. So several laboratory do some research work in this area, published some paper, and the paper shows. Look at the image. The paper shows good result. But as we know, we cannot. It's not done in clinical right now. So why we cannot? Why we can identify? We can use AI to identify the thinning on MRI, but cannot do the LGE in MRI. Look at this case. Look at this picture. Here, the top one is the LGE sequence, and the next one is the lower one is the thinning sequence. So in the anterior lateral, in LGE sequence, in the anterior lateral wall, there's some white point. The white area. So is this a real fibrosis or not? I always ask this question when I give speech, and nobody can answer. So why? Because in LGE sequence, we cannot make sure where is the inner border of the left ventricle. So how to resolve this? In our routine work, we always use MR thinning to make sure where the inner border of the left ventricle. In this case, we can say in the anterior lateral wall of the left ventricle, there's a lot of papillary muscle. So it's not a real LGE. It's a sac between the papillary muscle. This is how we evaluate LGE routine work. So if you only do border assessment, LGE assessment, only use LGE sequence, we cannot make it. It's LGE evaluating is a multimodality thing. We we have to use LG and Cine together to evaluate the fibrosis of the myocardium. So some team realized this problem. So they do some work to match LG sequence and the Cine sequence. But now it's very difficult. It's very difficult. So we cannot use it right now. But our team is doing this work right now. Hopefully we can make some progress. And the third one is diagnosis. And the third one, our CMR procedure is diagnosis and risk prediction. So diagnosis is, as a doctor, the final goal of our work is diagnosis and to therapy. So the final target of CMR is to diagnosis. So many teams, many research works in this area. In the earlier time, we can diagnose one disease, such as this paper, dilated cardiomyopathy. And with the development of technique of AI, we can diagnose the more disease can be identified. So I rapidly passed this PPT, and also can do some differential diagnosis like HHD and hypertension, heart disease, and HCM. So AI can find the difference between the two diseases. This paper, 4 diseases can be identified. Okay, I will introduce a very important paper published in Nature Medicine, and the paper in the earlier part of this year. I think this is a very a big step forward of cardiac MR. This work was done by Fuwai Hospital and Stanford Hospital. And Stanford University. In this paper, this paper is from China. They trained 10,000. They trained 10,000. Over 10,000 cases of cardiac MR, and include 11 diseases. After training, they promote a software. This software has the power to identify 11 type of cardiomyopathy. I think this is a big step forward of this our cardiac MRI. So we all very happy because AI in cardiac MR make a step forward, I think. But is this the end of our research in AI in CMRI? No, I think the disease understanding is unlimited, but is unlimited. So I will make a summary. So artificial intelligence offers unprecedented opportunities. In the future, we should make full use of existing cardiac imaging database to develop a more powerful algorithm, further reveal currently unknown clinical knowledge of heart health and disease, and build new software tools to make more benefit, make more care of the patient. Thank you.